Hello and welcome to my channel. My name is Peter Abraham. I'm a registered nurse with experience in cardiology, long-term care rehab, medical surgical, and primarily in hospice. I am a holistic nurse, meaning that I look at mind, body, spirit, and soul. In this channel, for which you're new to, if you're new to, welcome. We discuss things related to chronic illnesses that can become terminal, holistic nursing, hospice nursing, caregiving for hospice patients, as well as book writing, as I have written many books for both hospice nurses, holistic nurses, and caregivers. Uh, if this is what you like to see and hear, please subscribe, like what if you like, and please feel free to comment. This is a non-judgmental channel. I don't know it all, and I appreciate different points of view. Today's episode is going to be a continuation of overviewing the final chapters of the upcoming book, Hospice Clinical Pharmacology, Critical Thinking for Comfort-Centered Care. There are many books out there for clinical pharmacology, but I have not found any that are specific for hospice nurses. So that's my goal for this book, is to be specific for hospice nurses. Before I go too much further, in every single episode, I try to, and I encourage you to think about, what are you grateful for? I've lost track how many times as a hospice nurse I've been told, this, you have the hardest job on the planet. How do you deal with death in and death out? It's very rare for me to be present when somebody takes their last breath. Those of you who have been in the field of hospice or are, you know that hospice nurses, we come in, we do our visit. My home visits would average around an hour and 15 minutes to an hour and a half. My facility visits would probably be around 45 minutes to an hour. I tried to give the time that is due to them. I do know there are other nurses that are under pressure to do 30 minutes or shorter visits. My heart goes out to all of you. But it's very rare for us to be physically there. But I have had times where I'm there and they're having that death rattle and they take their last breath. I've been there where they've struggled and taken their last breath. And how do I deal with that day in and day out? Part of my answer, I'm an INFJ Myers-Briggs, so like an onion, multiple layers. Yes, it's Jesus. Yes, it's my prayer life. Yes, it's going out there and walking and gardening and doing other things. But one of the key elements, the top 5 list, the top 3 list, is gratitude, having a part of gratitude. So what are you grateful for? So I'm grateful for yet another day to live. Today is a beautiful day here in central Kentucky. I'm grateful that we've accomplished so much in such a short period of time with our brand new vegetable garden. Just got to plant strawberries for the first time just the other day. And I'm grateful to be able to share what I know about hospice, to be my geeky nerd self and share what I know with you. So without further ado, let's dive into this upcoming section that is going to be the overview. How do you make medical decisions as a hospice nurse with limited data? So I bit my teeth. That's not why I'm missing teeth on rural hospice nursing, where sometimes we have patients that, they've rarely gone to the doctor and they come on board. We did an eval, maybe I did the eval, they come on board. We have no laboratory data. Or they just came back from the hospital and all we have are the admission data. We don't have trends. So this section that we're going to see goes over what happens if we have data, how do we extrapolate and trend out that data with the understanding it's a clinical guess. And what do we do if we don't have any data? How do we make these judgments as to how do we do the S-bar to the provider? Um, and let's get into that now. Continuing with the overview of the upcoming book, Hospice Clinical Pharmacology, Critical Thinking for Comfort-Centered Care. This is the chapter dealing with medical decisions with limited data. So my foundation as a hospice nurse is in rural hospice. Sometimes we'd have the patient coming home from the hospital and we had the admission, like the labs that they obtained from when they were in the hospital. But more often than not, we get patients that may not have seen a doctor in years, but they're at a point where their doctor or our medical director got a hospice evaluation, they're eligible, and we don't have the lab work. Or maybe the lab work is incoming, but we don't have it now. How do we make these decisions? So this chapter deals with two different perspectives. What if we have the admission lab, the lab data from when they were admitted, but we may not get any other lab data from then on? And then what if we have no lab data at all? So this goes over looking at the challenges. We have the introduction, the learning objectives, and now we're going to get into what do we do if we have the lab work available? How do we maximize that one-time use? This is Microsoft Word, so that's not a misspelling when you see the red underline over there. It's literally the bun to creatinine ratio. I disagree with that wants a space there. That's its own fine print. So just looking at how do we interpret that data. Laboratory value, what does it mean to us? What does this mean in a terminal illness? And what does this mean as it relates to pharmacology in terms of the medication? Getting to the clinical function, clinical examples. Liver function when we have the lab values available. And what does that mean? One of the things that separates, or my goal to separate this book from other clinical pharmacology books out there, is everything is tightly focused to end of life, the last 6 months of life. And I understand the fine print. We have hospice patients. Not that I had President Jimmy Carter, but he was on hospice for over a year. Outside of the tail end of the bell curve, I should say, the one end of the bell curve where they're on for over a year, we're looking at 6 months or less. That's the tight focus. Now, this I mentioned when we have the lab values from admission, how do we extrapolate that down the road? What's the trend going to be? What's the projected trajectory? Clinical examples, renal dosing considerations, what medications, what medications are affected by very low albumin levels. Again, heavy on the clinical examples. How to do an integrated approach when you do have the lab values. And anticipating laboratory progression without follow-up testing. Just looking at the progression again. And at the end of the day, yes, this is an educated guess. But I'm trying to provide you the framework for how to make that educated guess. And yes, this is very detailed. That's why I try to use tables when appropriate to make it easier to read. Now, getting into the meat for my fellow rural hospice nurses, no lab data is available. What should we be looking at? So the distribution of edema, urinary patterns, jaundice, spider angiomas, the palmar erythema, so on and so forth. Again, clinical examples. Unexplained fevers. Um, One of the things mentioned here is serotonin syndrome. I've had patients go through serotonin syndrome. It literally, from my perspective, mimics terminal restlessness. And it's very easy to, if you don't treat from a point of view, they are dying. And you could argue, well, it's okay, they're on hospice. And this is not judgmental. From my perspective, I'm not God, I'm not going to judge you, but if you catch it, that serotonin syndrome, and you get them off what's the cause, you treat the cause, and they bounce back. From my point of view, you still fit into the hospice parameter because our goal is not to hasten death. Our goal is not to prolong life on purpose, and granted, you can get into fine-tooth ethics on that, but I'd rather err on they had a little bit longer with their family if I could take care of that. Anticholinergic, I still remember that from when I was preparing for my board, hot as a hatter, those acronyms. Looking at patterns and relationships and clinical examples. And then looking at organ-specific clinical assessments for medical decisions. So how can we tell approximately where they're at? And one of my mentors, she I don't know always how to word things. She was a micromanager from a management standpoint, but as a nurse, whoa! I adore her as a nurse. She was my first hospice mentor. Hi, Tara, if you're ever watching. I still remember the day where we both forgot our blood pressure cuff, and she grasped her arm, and she's holding that, and the stethoscope's underneath where she has, like she acted as the sphygmometer, and she was I believe she was very accurate at getting the blood pressure. And I'm like, my mouth was on the floor if my jaw could detach. She was that amazing, and still is an amazing nurse. So my hope is like one day I want to be like Tara. One day maybe you want to be like I do. Want to be able to look at somebody and be able to assess as much as possible, and be that nurse that everybody looks up to, because you could look at somebody without even lab values. You got your assessment, wham. And if I can help you along the way, if my name is never mentioned, that's fine, but I'm happy for you. You'll be my next hero, so to speak. Diuretic selection again. Give me one moment here. Oh, I see what happened. Again, this is draft. So thankfully that was caught. And so intervention strategies based on mental assessment. Let me make that 4. So clinical examples, medical selections if we're not sure. And one of the things I have at several areas of this book, at least two that I'm aware of, use your resources. So you're out in the field and you don't have this book with you, or you forgot. Or maybe you see this, what I'm showing you, and you saw it on YouTube and you don't buy the book. You're still one of my heroes. Call your pharmacist and say, this is what I am seeing. Always offer your thoughts. That's one of the lessons I learned when I first became a nurse. This is what I'm thinking, even if it's basic. What are your thoughts? Correct me if I'm wrong. Tell me your thoughts. In that way, when you go to the doctor to give your SBAR or your CUSS or your DESC, you have evidence-based from a pharmacologist. Your pharmacologist can be your best friend, so to speak. Getting in some clinical examples. Looking at a guide for central nervous system. Clinical examples. I'm trying to be as thorough as possible to help you do the best that you can. Practical approach to dosing assessments. What about cardiopulmonary? Respiratory patterns. This is where in a previous video mentioned about I had made a correction on the respiratory rate. It was 10 and 24 when it should be under 8 and over 28. Oxygen saturation. And while I have numbers represented in this book, I cannot emphasize enough, be very careful for treating just based on the numbers. Always evaluate before and after. And everything is prognosis driven. We're soon coming up to the end of the cardiopulmonary chapter. Clinical examples, prognosis-based deep prescribing. I cannot emphasize enough, help all of your hospice patients, work with them to buy into and the provider to buy into, get them off those statins. You'll reduce polypharmacy. It's one of those medications you don't have to monitor after deprescription. Some of your providers might want you titrating based on the dose. Anticholinergic burden assessment. Swallowing, you're going to assess for swallowing, adverse versus benefit. And then we get into our case studies. Limited renal data. What does that look like? Opioid selection when you don't have liver laboratory data. Intervention and rationale. Anticoagulant management without coagulation studies. And yes, you can obtain oral vitamin K in a worst case situation. diuretic selection, along with the rationale and follow-up monitoring, antipsychotic management. And then we're getting into the conclusion, along with discussion, questions, practice scenarios, and Socratic questions. Thank you for your time watching that overview. The final draft of this upcoming book is currently being reviewed for any uh, minor edits and changes, including illustrations as applicable. I'm hoping for publication this Easter weekend. I do thank you for your support, for each and every one of you who have purchased or are going to purchase any of the books that I've written to empower my fellow hospice nurses and holistic nurses and caregivers. Thank you so much. Please feel free to comment in the area below any questions that you might have, whether it be about this book, writing books, healthcare topics that I may be able to assist with the understanding I'm not forming a nurse to patient relationship with you, and I certainly don't have all the answers. Thank you so much for your time, and God bless.